Okay, hello everyone. My name is George Mavros, President of Stanford Club of Greece, and I would like to welcome you to our second virtual speaker event, which is part of a series we have launched titled Deconstructing COVID-19, Reconstructing the Economy. Our goal is to hold such webcasts with guest speakers that can offer us useful insights on the global pandemic from a medical point of view, but also from an economic point of view. Before I introduce and welcome our guest speaker for today, I would like to let you know that following Dr. Ioannidis' presentation, I will moderate a Q&A session, so feel free to type in your questions in the Q&A box provided by Zoom, and I will make sure to monitor, group, and convey as many of them as possible to our speaker. We're very pleased to see that our event drew a lot of interest from around the world and that we have a truly international audience from Greece, Switzerland, the UK, France, the USA, and other countries. I'm sure that the main reason for this interest is our speaker, Dr. John Ioannidis, and who I will now introduce and welcome. Dr. John P.A. Ioannidis, MD, DSc, holds the C.F. Renberg Chair in Disease Prevention at Stanford, where he is Professor of Medicine, Professor of Epidemiology and Population Health, and Professor by courtesy of Biomedical Data Science at the School of Medicine, Professor of Statistics at the School of Humanities and Sciences, and co-director of the Meta Research Innovation Center at Stanford. He is the recipient of many awards, and he has been elected as Einstein Fellow at the Berlin Institute of Health. He has been inducted in the Association of American Physicians, the European Academy of Cancer Sciences, the American Epidemiological Society, the European Academy of Sciences and Arts, and the US National Academy of Medicine. He has received honorary titles from Forth and the University of Ioannina, honorary doctorates from the University of Rotterdam, University of Athens, University of Tilburg, and multiple honorary lectureships. He has published 7 literature books in Greek, the last 4 of them by the Kedros Publishing House, and 3 of them being shortlisted for the Best Book of the Year Anagnostis Awards. His Public Library of Science medicine paper on why most published research findings are false has been the most accessed article in the history of Public Library of Sciences, with more than 3 million hits. He's among the 10 scientists with the highest current citation rate in the world, approximately 4,500 new citations per month per Google Scholar. In his website, he states that he loves to be constantly reminded that he knows next to nothing. Today's webcast by Professor Ioannidis will delineate efforts to understand the magnitude of risk conferred by COVID-19 and the gradient of risk across different populations and settings. It will also present data that try to assess the prevalence of the infection, since many infected people are asymptomatic or have very limited symptoms and thus are not tested. Furthermore, it will also provide an overview of the research agenda on rigorous testing and evaluation of interventions against COVID-19 and the caveats thereof. Finally, the implications of emerging evidence for high-stake decisions will be discussed. John, thank you very much for accepting our invitation. I would like now to welcome you and give you the floor.
Thank you, George. It's a great honor for me to be invited to give this webinar, and I'm grateful to the Stanford Club of Greece for organizing this event. Let me see if I can share my screen. Okay, is it visible?
Yes, it is.
Perfect. So I will try to cover a lot of ground within the next 35 minutes. And I have to say that there is a chance that much of what I will say still has a substantial amount of uncertainty and controversy. But I think that we have learned a lot over the last several months about COVID-19 in terms of its risks, its prevalence, what kind of evidence we have, what kind of evidence we lack, and how can we use that evidence, that information, science, to make the best decisions in what is a major global crisis. Interesting. The screen seems to be frozen. Okay. So some disclosures about conflicts of interest, and just acknowledging the fact that I apologize that I have no personal social media accounts. In the COVID-19 pandemic, this has become kind of a nuisance and a blessing at the same time. I make lots of errors, and I don't want to compound them with making even more errors in social media where people need to write very quickly. Here's a few statements about COVID-19. Are they true? COVID-19 is a very serious threat. It is very unpredictable. It is the pandemic of a century, similar to influenza in 1918. It is the top cause of death in 2020, outpacing all other causes. The infectious disease that has killed more people than any other in our generation. Let's go through them. Indeed, COVID-19 is a very, very serious threat. There's no doubt about it. Indeed, it is very unpredictable. We are constantly surprised from what we learn, from how much we realize that we didn't know about COVID and what we should do about it. However, the person years lost with COVID-19 to date are just 1,000th of 1918 influenza. And actually, if you compare with other causes of death, there's many others that do much worse. Smoking, for example, will kill another 9 million people this year, like every year. Smoking will kill about 1 billion people in a century unless we do something. It's not even number one in the infectious disease league. Tuberculosis has killed 1 billion people in the last 2 centuries. It's an ongoing pandemic. It still kills 1.5 million people every year. And unfortunately, the lockdown measures for COVID-19, especially prolonged, there's some modeling that suggests that we are risking killing 1.4 million extra people with tuberculosis because of these measures in the next 5 years. When we first met the virus and we heard the horrible news from China and then also horrible news from Lombardy, many scientists, among the best scientists in the world, tried to model the impact of COVID-19. We had a lot of forecasts that were really doomsday forecasts. The assumption was that eventually, since this is a new virus, we have no immunity to it, eventually up to 8% of the global population will be infected. WHO early in March came up with a 3.4 case fatality rate. The envoy to China said there's very few asymptomatic patients. Gradually, the infection fatality rate was dialed back to a bit over 1% or close to that. But still, this is tremendously high. If you run the calculations, this means 50 million deaths. The Imperial College predicted 2.2 million deaths in the US alone, and entirely overrun healthcare systems were forecasted by multiple models. So flattening the curve became like the motto of the day, of the week, of the month. And here's a few items from the news, from newspapers, disseminating this information to the general public for New York. The prediction was that we would need 140,000 hospital beds, and as many as 40,000 intensive care units with ventilators. For Tennessee, 2.5 thousand ICU beds and nearly 2,000 ventilators. And California was at the brim of catastrophe in mid-March, requiring 50,000 additional hospital beds compared to what it had. What happened eventually was really horrible in some locations, and we lament the loss of life. New York was extremely hard hit, but even in New York, the ICU beds that were required reached up to 5,000, not 40,000. And the total number hospitalized with the virus reached somewhere in the vicinity of 20,000 at the top, instead of 140,000 that were the predictions. In Tennessee, that was far less hit. Instead of 15,000 inpatient beds and 2,500 ICU beds, we had 1,200 inpatient beds and 245 ICU beds. And California actually did surprisingly well. COVID-19 patients occupied fewer than 2 in 10 ICU units, and under 5% of general hospital beds were occupied by COVID-19 patients, as you see in that news coverage. Here's some of these predictions. This is the IHME model. It's a model that is data-driven. It's not speculation, because most of the models that circulated in this pandemic were based on variants of the SIR model that was introduced in 1927, which is a theoretical model. It makes lots of assumptions. Of course, most of these assumptions cannot be real in real life. But this is a data-driven model, meaning that it looks at the data, it tries to use very fancy, sophisticated methods. It has the best scientists trying to build it, and it uses evidence from similar experiences in other locations around the world. And you can see at the far right that the prediction for New York was completely off. The prediction for New Jersey was actually an underestimate, and the prediction for California did kind of modestly well, but missed the shape of the eventual epidemic in terms of ICU bed requirements. This is looking at 4 models that were created by some of the best scientists in the world in terms of how often they predicted the number of deaths in the next day, like 24 hours. I'm not asking for a prediction what will happen by the end of the season, just what will happen next day with less than 10% error. And as you can see, none of them really did even modestly well. All of them really did very poorly. If you see red, it means that barely 40% of the time, it managed to have less than 10% error for the next day. If you see blue, it means that no time, or 10%, or maybe 20% if you see white or very dim blue, managed to get to that level of error. And here's what happens if you take into account also the 95% prediction interval. So the entire uncertainty in the prediction, only one of the 4 models does manage to have pretty good coverage, 95% of the time being about right if you take the wide prediction interval of what will happen in a probabilistic manner 95% of the time. Even in a waning epidemic wave, prediction can be very tough. So these are data from the US, number of incident deaths per week. This is a snapshot that I took early in June. I think it was June 2nd, trying to see what are the predictions of 8 models about what will happen in the subsequent weeks. Already, what is happening is below the prediction of the most favorable model, more or less. Why is that? We were lucky, we did the right thing. The virus is such, or all of that, but epidemic waves with coronavirus, they're not exponential waves. They resemble mostly what we call Gombert's functions, as my colleague at Stanford and Nobel laureate, Michael Levitt, has described for a number of months now, actually, since he started working on the pandemic on China. These waves die off, they plateau and die off. And I have plotted for you the most hard-hit locations in the world, more or less. And you can see the wave rising with an exponential or close to exponential phase, but then reaching a peak and then declining. And this is the number of deaths, which is a better reflection of what's really happening, because the number of cases is mostly reflecting what we're testing. If you test a lot, you will find a lot of cases. If you test not a lot, you will see a modest number of cases. If you don't test at all, you will not document any cases, but of course, people will still be dying. Let's take a look at the age distribution of deaths. Again, these are data looking at the locations around the world that have been the most hard hit and that started being hit pretty early. I have added here also Mexico and India, which are 2 locations that started a bit later, but are also major epicenters. As you see, the majority of COVID-19 deaths occur in the age stratum above age 80. And then a very large share occurs in the age stratum 65 to 79. If you look at what's happening below 40 years old, it's extremely rare, with the exception of India and Mexico that have very young populations. And India has 1/10 of the proportion of population being above 80 compared to Italy. So not surprisingly, you will get fewer deaths in that age stratum because there's not too many people in India who are that elderly. This is looking at the death risk of people who are more than 65 years old versus those who are less than 65 years old. And on the top, there are various countries. On the bottom, you have US locations. In Canada, people who are above 65 have 100 times more risk of death compared to those who are less than 65. And these people account for 82.3% of the general population. In Switzerland, it's about 80-fold. In Ireland, it's 76. In most European countries, it's between 30 and 100-fold difference. It's a huge difference for epidemiology. These are the types of risks that we very rarely encounter, but when you encounter them, you know that this is a disease that is extremely different for different people. Almost the same thing in US. These are data that have still not incorporated probably all the nursing home deaths. So the relative risk varies from 16 to 52-fold in Massachusetts. You see again the difference in India and Mexico, where the relative risk is only 8 and 9-fold, presumably because there's very few people who are reaching high age in these locations, and those who do are probably in fairly good health in order to survive and reach to that age. Or there's other reasons that we don't know yet why this is happening. These are data from the UK project, Open Safely, and you can see the cumulative probability of hospital COVID-19 death as a function of time for different age groups. If you compare people who are over 80 versus little kids, the difference is about 1,000-fold different risk. We're talking about a completely different disease if you compare age extremes. And these are data from the same analysis of the Open Safely Collaborative Group that show that we have strong risk factors beyond age, which age is an amazingly strong risk factor. We have other risk factors that can also offer us some granularity about the level of risk. I would focus on a couple of them. Deprivation is a very strong risk factor. COVID-19 is a disease of inequality. It breeds on inequality. It hits disadvantaged people, people who we have discarded from our society, that we don't give them enough attention, that unfortunately we do that. We protect ourselves with shelter in place and with staying at our houses, but there's people out there who are homeless, who need to work with low salaries in very dangerous situations. A few other situations, some types of diseases increase the risk. For example, hematological malignancy, if you had a hematological malignancy, especially pretty recently, or if you have an organ transplant, again, you have substantially higher risk. You have 3 to 4 times higher risk of death. However, when people were talking about underlying diseases, they were thinking more about something like hypertension. And everyone was scared because they said that, well, if people with hypertension are at very high risk of dying, then we're stuck because hypertension is so common in the general population. If you look at that plot, hypertension actually has absolutely no increase in the risk of death. You look at things like asthma. If we're not talking about asthma with systemic use, it hardly has any impact. If we're talking about asthma with systemic corticosteroid use, it has a 1.3 hazard ratio, which is really tiny. So we have more information now about the risk profile, and we can build models that can tell us who are the people who are at higher risk. These people are really not that many, especially if you think of a substantially higher risk. If you're thinking about small increases, yes, but these small increases probably don't have much consequence. So here's how it looks like based on what we know now. I have plotted for you the distribution of a population in a country like the US, and I have split down the population to age 0 to 49, 50 to 64, more than 64, and you have a very thin slice in the center, which is nursing home. People at nursing home situations are about 0.5% of the entire population in the US. You have also some other bold slices, which are the segment of the population who are at high risk. People who would have to use some extra precautions that we need to protect extra cautiously if we want to avoid disaster. And you see that these slices are very thin. Cumulatively, these slices are about 9% of the US population. Actually, in most European countries, they would be even less than that, because the gradients of risk in European countries are even steeper than the US. So we would be talking about something like 6% or 7% of the entire population. How does that translate in terms of the COVID-19 deaths by age risk category? About 50% of deaths are happening in nursing homes. And then you have these other slices, which are in dark color, which represent those other people who are at high risk. If you add these up, you explain about 91, 92% of all the deaths from what is 9% of the population. So clearly, we have a situation where we have learned that the risk has tremendously steep gradient, and we can identify who are the people at risk. And then that means that we need to do something about them to protect them. What can we do to protect them? So we all know that it's good to wash our hands, so we should know that. There's even randomized trials that say that washing your hands decreases the odds of infections that are respiratory infections like influenza, and probably the same thing for COVID-19, by about 40%. Wearing masks in proper situations pretty much does the same thing, another 40, maybe 50%. But how about the more aggressive measures like social distancing and lockdown? Now, what is lockdown? There's hundreds of measures that are included in the bundle of social distancing and lockdown. Their implementation is totally arbitrary. If you take two countries and you compare what they did, the devil is in the details. They both might have said we went into lockdown, but how exactly and in what sequence and how strongly it was enforced and what kind of adherence and fines and whatever, it would be different. Do we have randomized trials on lockdown? Not really. There's 1,300 ongoing or planned trials on COVID-19. None of them are on social distancing. It's everything about treatment and a little bit about prevention and a few vaccine trials, but nothing on social distancing. So what do we mean by social distancing and lockdown? And can we even test these measures? I would argue that we could test them. We can start by thinking, what are the options? And here's like a partial list of options and several ways that these could be implemented. Different ways of implementation can be compared. They can be compared in observational studies, but they can be compared, I would argue, even in randomized trials. So if we're talking about physical distance, in France or Italy, this is 1 meter. In Australia, this is 1.5 meters. In US or UK, it's 6 foot. In some other locations or groups, people might be thinking of 3 meters. And with forceful cough, maybe the virus can reach up to 6 meters, although I'm not saying that people should really stay apart for 6 meters because of that. Most evidence suggests that probably even 1 meter might be enough, or maybe even that might not be necessary under specific circumstances. Can we test that? Closure of spaces where people can meet. We need to decide on whether we're talking about complete closure or some sort of function might still be allowed. There's so much debate about schools, which grades, which levels of education, whether there's any levels that should be allowed in parallel or not. Workplace, places of worship, pools, gyms, clubs, restaurants, bars, shops, which ones, outdoor areas, parks, beaches, mass transit, non-essential businesses, services. What is non-essential? Even that has to be defined, and it can be compared. Cancellations of events where many people could meet. What kind of limit are we talking about? Less than 10, less than 50, less than 1,000. Travel restrictions can have a very wide range. Quarantine can vary from single person to whole provinces, or something like Ebola, which is a cordon sanitaire. You don't let anyone go in or out. For how long? How strictly enforced? Outdoor activities, what kind of interactions are allowed? Do you allow lockdown buddies? Is that an option? How much contact tracing should be done? How it should be done? How feasible is it in doing it? And finally, screening. All of these are implemented to different degrees and with different levels of adherence. But to be honest, I'm sure that many of these measures work. I just don't know which ones. And some of those are likely to be more effective and least disruptive compared to others. How would we know that we're doing more good rather than harm? Well, we need to decide on all of these aspects of these measures. We need to decide on the timing, the duration of their implementation, the sequencing, the combination. How do we enforce adherence? How do we wean these measures? We're pretty much in that situation in most places around the world at the moment. How do we get rid of these measures without really having a recrudescence of the epidemic waves? How do we measure that we're doing what we're supposed to do? Are we using response indicators and surrogates? What is the target group that we're choosing to implement or de-implement these measures? And what is the setting? Are we locking down the entire world, a country, a town, a facility, nursing homes, hospitals, or even more precisely localized? All of these are questions that I think should be subjected to scientific investigation. We have very limited knowledge, and we may be lucky that we will never see a second wave, but we may see a second wave. And then we would need to know better which measures at what stage, with what sequence, for how long, and in what combination would be best to try to achieve. For example, you can have preemptive measures where you shut down the entire world waiting for a wave that hasn't started. Is that a good idea? Early in the course of the epidemic, this sounds like a good idea, so as you do not have a wave that is rising very fast. Or late. Actually, is late doing any good, or is it just too late and maybe things are getting worse? All of these are really open question largely, and I think that we need some better evidence. How would we get this evidence? What kind of things should we measure? Right now, we're mostly measuring infections, which is unfortunately just the tip of the iceberg. Infections is just those infections that we see. We can also measure hospitalizations, which is a bit more hard outcomes. We can measure ICU bed use. We can also measure deaths, but even deaths, we have so much uncertainty when we're talking about COVID deaths on whether we're talking about deaths by COVID or deaths with COVID or deaths that are supposed to be COVID, but we have not even documented COVID, which is the expanded definition that many countries have applied already. How about other dimensions though? How about quality of life? How about impact on other aspects of health or on health utilization or social indicators like violence, like suicides, like unemployment, like domestic violence? When are we measuring those? How are we measuring those? Are we waiting for people to jump off their balcony and say, here's a suicide? Is that passive? Do we go for active documentation of mental health impact, systematic at different levels of intensity? What's the relevant horizon? Are we interested just to cut down the number of cases in the next couple of weeks? Or are we interested to capture the consequences of unemployment, of suicides, of ruined mental health, of disrupted health systems over months and years, which may outnumber the impact of COVID-19 by 5 or 10 or 50-fold? How do we devise capturing cost effectiveness at short, medium, and longer term? And how do we translate different indicators on health, health system, society, environment, and economy? All of these are challenging questions. The news have created probably a lot of horror stories. One of the common horror stories is that young people are dying with COVID-19. Young people can get something like Kawasaki disease, which is something of concern, but people who are young, children in particular, are not dying with COVID-19. Here's a crude estimation trying to show to you how big is the risk for someone who's less than 65 years old, translating the risk to equivalence of death risk for traveling by a motor vehicle. And I'm using here calculations only for the most hard-hit places around the world. So this is the worst of the worst estimators that you can get. And I'm showing them for May 1st, when these estimators were at their peak. So since then, they have gone down. You see that compared to the average commute in the US, which is 31.5 miles per day, the risk, even in the worst hit epicenters around the world, even at the peak of that risk, is not really much higher. And in most situations, it is even lower. So the risk, even in these epicenters, is like driving from home to work on a regular day. There's some exceptions. There's New Jersey and New York. The risk there is about the same as a truck driver who drives from Manhattan to Washington, D.C. every day. But there's people who do that for a job, for a living, and they do that every day. If you further focus on people who are less than 65 years old but have no underlying diseases, the percentage of deaths among these people, the share of deaths by COVID-19 accounted by these people is extremely tiny. New York City, it's only 0.6% of all deaths are in people who are less than 65 and have no other reasons to die, in a way. In France, it is higher, it is 2.6%, but actually these data come from death certificates that have very limited information very often about many diseases. So probably this is an inflated rate. Italy, 0.7% is about right. Sweden seems high at 2.2%, but actually this includes only 4 other types of comorbidities, and there's many others. If these others had been captured, the rate would have been substantially lower. How widely spread is the infection? This is another tantalizing question. How common is the infection? And of course, how lethal is it? And these two go together because we can see the number of deaths with all the caveats about what it means to have a COVID-19 death. But if you have a very common infection, then on average, probably that infection is not so lethal for each individual. If you have a rare infection, then this means that it's very lethal for each person who is infected. There's a high risk of dying. This answer is very difficult to answer because people are different in terms of their susceptibility to the virus, in terms of what are the chances of dying, as I just showed you. But it's also likely that the spread of the infection is very different in different locations, but also within the same location when we're talking about people of different ethnicity, different backgrounds, different exposures. For example, in the Santa Clara study, we found that the Hispanic background population had 5 times higher seroprevalence compared to the white population. And people who you will capture in a seroprevalence study are unlikely to be those who have the highest risk of exposure and the highest risk of infection. For example, it's unlikely that you will get homeless people. It's unlikely that you will get the most disadvantaged strata of the population that are those that are at the highest risk among the general population. Here's an overview of 23 seroprevalence studies that have been presented in complete papers, either in peer-reviewed journals or in preprints, and they cover a very wide spectrum. What I'm showing you here is their sample size, the type of antibodies that have been used, the population, the region, and the percentage of the population who's less than 70 years in that location. Now, these seroprevalence studies mostly measure one antibody, IgG. A few of them measure both IgG and IgM, and a couple also measure IgA, or they may measure 2 of the 3. And this already means that a lot of people who have seroconverted will not be captured. It also means that many people who have been exposed to the virus and have handled the virus but did not mount a response in the serum or plasma will not be captured. And we know from respiratory viruses like influenza, and we have some data also in coronavirus, that many people encounter the virus, they launch an immune response in the epithelia, in the mucosa of their nose or their upper respiratory tract. For example, they generate IgA that is locally produced, takes care of the virus, or they have cellular immunity or innate immunity that takes care of the virus. They never develop antibodies. So the seroprevalence is likely to be an underestimate of the proportion of people who have encountered the virus. This is the range of values that you get for seroprevalence in these locations. And you see that they are widely different. In some locations, it's very barely distinguishable from 0%. And in other locations, it's as high as 47%. For example, Brooklyn, there's a seroprevalence study that found 47% of the population having antibodies to coronavirus. And this is an effort to calculate the infection fatality rate for all of these locations based on these data. Many people think of the infection fatality rate as a physical constant, or as the KM standard of an enzyme reaction, or as the atomic molecular weight of an element, like a fixed thing. And it is not a fixed thing. Infection fatality rate is likely to vary a lot depending on who are the people infected in each location, what is their age and risk profile, how are we managing the infection, what are we doing about treating these people. And not surprisingly, you see tremendous variability across different locations. Some locations have an overall population infection fatality rate as low as 0.02 in Japan, and others go up to 0.8 in locations in Italy that were very hard hit. If you look at the infection fatality rate in people less than 70, then you see much, much lower values. And on average, it is about 0.03 to 0.04 as compared to 0.25 for a median in the overall population. But even there, you see situations where the infection fatality rate is close to 0.00, and you see others like New York that it's up to 0.23, even in that population. So what have we learned? We've learned that the infection fatality rate can vary a lot, from 1/5 of influenza to 10 times or more of influenza. Infection fatality rate is not a constant. It depends on all of these factors that I alluded to. But the good news is that since we know many of these factors now, we can make the infection fatality rate much lower. We know who and where to protect so as to avoid massacres. Another major misconception is how many people have to be infected. Models say that 60%, 80% need to be infected to reach herd immunity. However, these quotes assume homogeneity of mixing of populations, something that never happens and rarely gets approximated in real life. The epidemic wave may end in some, many, most places with far lower percentage of people being infected. Second waves, possible. I have no clue. They may well happen. We should not say that we're free and we're safe. That would be a complete misconception. But we just don't know when, if, how they may happen. We just need to be prepared for them. Evidence exists. There's a very nice paper in Cell that says that about 50% of the unexposed population already has CD4 cellular immune responses to SARS-CoV-2, suggesting potential cross-immunity from garden variety coronaviruses. If this is true, it may also explain why the epidemic waves kind of stop with low percentages of people being infected in some locations. There are some special settings that I think we can do much better. One of them is hospitals and healthcare workers. There was a lot of debate about whether healthcare workers are infected, whether there can be a problem with nosocomial infection. I think that we know. We know that clearly in early locations that were disasters like Wuhan and Lombardy, nosocomial infection was a key feature of the problem. In other locations like New York, I suspect it was just the same. In Lombardy, we know now that 4 to 43% of healthcare workers have seropositivity. In Barcelona, it's 15%. Even in Utah, that is a place that hardly had any epidemic wave, 5 to 7% of emergency healthcare workers had antibodies. And of course, it's lower in some other locations. I'm showing you here some plots that we've run with David Grimes from Queen's University, looking at the epidemic within healthcare workers. And you can think of that epidemic as having two components. One is the infection of healthcare workers in the community, and the other is the infection of healthcare workers within the hospital environment. And we have many ways to protect them, of course, if we know, and now we know. And I would argue we have many ways to protect them further by testing them, because many of these infections are asymptomatic or mildly symptomatic. Asymptomatic infection, the invisible. This is really the greatest mystery, I think, of that whole epidemic. There has been lots of back and forth about how common it is and what it does. Now, what does it mean to have symptoms? To be honest, I don't know. Do I have symptoms? No, I don't. But if I start asking myself, are you feeling not 100%? I never feel 100% in my life. Every day I feel 97%, 94%, 90%. Did you cough at all? Of course I did, every day, and I'm not sick. So if you ask about symptoms, you will get more people who report symptoms. But if you just say, did you go to test yourself because you felt that you had enough symptoms to be tested? I think this is a very different story. This is some work that I've done with Ellen Kuhl's team from Stanford, where we've tried to model in an SEISIAR model the contribution of asymptomatic infection. And it seems to be substantial. I mean, clearly we're dealing with a large component of the epidemic. The exact contribution to transmission is something that can still be debated, but clearly we have a big iceberg that is below that tip. How much can we expect from clinical trials? We have many of them. I'm showing you here the analysis that we did as part of the COVID evidence database that I have been building along with many other colleagues led by Lars Hemkins in the University of Basel. A huge number of clinical trials were launched trying to understand what we can do to treat that infection and less so what we can do to prevent. And as I said, nothing on social distancing. There's more than 1,300 trials that are planned or are started. However, the bad news is that only 28 trials have been completed to date. Is that bad news? Maybe it's not bad news. Maybe it's good news because it means that they're having problems recruiting because there's no patients in Europe and in the US, where most of these trials have tried to accumulate their sample sizes. My guess is that 80% of them will be abandoned. Now we have a second wave, of course they will not, but of course I don't want us to have a second wave so that clinical trials can be done. I'd rather see no second wave coming, hopefully, but who knows. So far there's only one possible success, and this is dexamethasone. Very nice data from the trial led by Oxford, Martin Landray, a great friend and a wonderful scientist. Unfortunately, this is just a press release as of today, and I really want to wait and see the full paper, but we have at least one possibility of one intervention that may be working, and it may make a difference in our planning for the future. There's a lot of ridiculous and hypocritical quotes and news during the pandemic that confuse the whole story. I've made my collection of them, and here's my vote for the most ridiculous and hypocritical incident. It's news from Greece, March 17, the tobacco company Papastratos, the Greek Philip Morris affiliate, donated 50 ventilators for intensive care units. I think we should not lose track that COVID-19 is a major, major problem, but there's many other problems. And as we restructure our world to have a better world in the future, a better world for all of us, even more so for those who are not equal, unfortunately, because as I said, COVID-19 is a disease of inequality. Just sanctifying tobacco industry that is killing 10 million people, 9 million people every year is not the way to go. What should we do? There's many things that we should do, and I think that many of those should work. There's many recipes of success. One recipe of success is Singapore and Taiwan. Intense early testing combined with contact tracing in the early phase before the epidemic wave established itself. Singapore documented 42,000 infections, only 26 deaths for a population of 5 million people. 26 divided by 42,000, this is an infection fatality rate of 0.06. So it's very, very low, and it may even be lower if some infections were not documented. Good to do this again, to pick any resurgence of a second wave. For countries that did well or for countries that failed, now that things are controlled, I think that they should try to pick up the second wave before it starts, before it becomes a wave. I would also argue we need to perform rigorous epidemiologic surveillance on representative samples of the population, or use other means. For example, checking for virus in sewage is one interesting idea, but we have to see whether it will pan out, to make sure that we see that recrudescence of a second wave early on and we just extinguish it. Employ information on risk distribution. We have tremendous information. Epidemiology has rarely been so successful to identify such tremendous risk gradients. We need to make use of them. We need to protect those people and those locations that need to be protected. On the top of my list, hospitals and nursing homes. We need draconian hygiene and infection control measures. We need to test all personnel. We need to test nursing home residents regularly. more frequently in periods of resurgence or activity of the epidemic being suspected. People who were infected in nursing homes, New England Journal of Medicine paper shows 25% infection fatality rate compared to the 0.00 something for average young people out there in the community. Protect with draconian measures about 5 to 10% of the population, probably no more than that. Protect other high-risk settings like meat processing plants, prisons, homeless shelters, ships. Use standard measures that are known to work for the rest of the general population. Hand washing, respiratory etiquette, masks when appropriate, some non-disruptive distancing. All of that makes sense. It's easy to do. It will not disrupt our life. We can go back to our normal life and our normal activities. As I said, COVID-19 is a disease of inequality, and it creates more inequality. The more it gets prolonged and the more that we prolong our measures, we are creating more disadvantaged people. We are creating unemployed people who will lose their health insurance. They will become more unequal to the rest of us. So we need to protect the disadvantaged and avoid creating more disadvantaged people. Eventually, please don't destroy the whole world with aggressive measures, please. Many, many thanks to a very, very large number of my colleagues who have taught me a lot during this pandemic. I list here a few of them with whom I have collaborated in some of the work that I showed you today. But I think that in the last 3 months, I have learned a lot. I have learned that I know very little or close to nothing, next to nothing. I think that people who have criticized my work are my benefactors, and I thank them even more. And I hope that we will learn even more, and I hope that by learning we can save lives. Thank you.
Thank you very much, Professor. I think it was a presentation where in half an hour you have distilled an enormous amount of information and insights. I think you've covered a great deal of ground and gone into details in a lot of them. Looking at the questions from the audience, we will be able perhaps to go into a bit more detail in some of the areas. But overall, I have to say that it was very impressive, the level that you have gone into details and the information you have shared with us. If we can go into a few questions now, if that's okay with you. I will try to group them as much as possible because we have a huge audience, and I already see a queue of about 37 questions. So we won't be able to go into every single one of them, but we can certainly group them into specific areas and try to cover as much as possible. One of the areas that keeps coming up has to do with the antibodies and the immunity. If someone has been infected by the virus and has recovered and has antibodies, a common question is, for how long will he be able to be immune to the virus? And also, building on that, is it possible that certain countries, their population is less susceptible to the virus because they might have antibodies from previous coronaviruses in the past years, or from other factors that may make a certain country's population less susceptible to the virus?
That's a very important question. And we know some aspects of giving an answer to that, but there's still a lot of unknowns. Antibodies do not offer a passport of immunity. So an antibody test should not be seen as proof that someone is immune, will never be infected again. Conversely, someone who does not have antibodies does not mean that he may not be immune in one way or another. Antibodies are a surrogate. It's a surrogate marker. It says that our body has encountered the virus and it has generated one type of immune response that we can detect in the blood, serum, or plasma. Our body may have encountered the virus and may have dealt with that in many different ways. There's many paths of immunity, And it's possible that for a coronavirus like SARS-CoV-2, innate immunity or cellular immunity or antibodies, but not systemic antibodies, localized epithelial response in the mucosa and the upper respiratory tract may be as important or even more important than the antibodies that we detect as part of testing blood samples. As I said, we just don't know how much cross-immunity there is with other coronaviruses. If there is cross-immunity, the most likely scenario based on the data that we have is that it's not antibodies necessarily. It could be cellular immunity like CD4 responses that may be good enough to handle the virus. Now, if that's the case, it may also explain why some populations are more recalcitrant in dealing with this pandemic. And for example, Asia seems to have done very well. If you look at the infection fatality rates, I mentioned Singapore, Japan, South Korea, they seem to be much lower compared to, and even China, which people question the validity of the data, of course, they seem to be much lower compared to several Western European locations or some parts like New York. It's a mystery. Some of that may be how we handled and managed the pandemic or how we let our nursing homes be devastated. But it could be that there's some differences in some background immunity. It's very speculative at the moment. You can see it as good news or bad news. I would see it mostly as good news because the fact that the epidemic waves are stopping, to me, that suggests that there's something there, possibly some immunity that we haven't characterized very well. Rather than bad news, I will be infected again. I wouldn't see it as bad news, mostly as good news.
Okay, thank you. Regarding the possibility of the vaccine or an antiviral medication, where do you, let's say, pin your hopes more in terms of having an impact on the spread of the virus or the severity of the virus in the let's say next 6 to 12 months? Would you say that is it more, our hope should be more in the vaccine side or more in the antiviral medication side?
So as far as medication, as I mentioned, we have dexamethasone showing these promising results in one large trial, and I'm waiting to see the full paper because the way that it was presented in the press release was very peculiar. Instead of showing the overall analysis of all the patients randomized, the presentation focused on a subgroup analysis showing that the risk of death is decreasing about 1/3 in those people who are in ventilator, in ICU, and it decreases by 20% in those people who are hospitalized. And actually, it seems to increase in those people who are with early, non-severe disease, but not significantly so. So it's a very weird way to present a clinical trial, kind of showing the details instead of showing the key result. I'd like to see the full paper, but if it's true, then it means that we have at least one option that may save some lives, especially in situations of very serious infection. It's not a panacea though. Obviously we don't know what is the long-term effectiveness. You know, if you save lives for 28 days, but these people die after 3 months, have you done much? So treatment, I believe we may have 1 or 2, who knows, choices within the next several months. I don't expect any spectacular success, but modest effects are possible, which could be helpful. It would be helpful, but not definitive. Vaccine would be definitive, but it takes time, especially to do it right. Vaccines are probably the greatest contributions of medical science to humanity. You know, things like MMR have tremendous impact on life. And actually what I worry is that the lockdown measures are delaying the implementation of MMR vaccination around the world, which means that we may be threatening hundreds of thousands of lives of children if we don't vaccinate them with vaccines that we have already available and they are effective while we're waiting to find the new coronavirus vaccine. So coronaviruses, there have been efforts for human vaccines for many decades now. They have not gone very far. We don't even know whether the problem with coronavirus disease is mostly the virus itself or the immune response to the virus. And it seems that perhaps it's mostly the immune response. The virus itself is okay, but our immune system is launching a response against it that is destroying our own body eventually. So if that's the case, you don't want a vaccine. you already have a very different type of response that is causing the problem. I do hope that we will get vaccines. I mean, there's lots of very smart people and great scientists working on them. And I believe that they may come up with something, but then it needs to be very thoroughly tested. And then it also needs to be produced. And our production chain usually takes another 6 to 12 months minimum. And then there's all these issues about how you distribute it and how you use it. So we need to solve this problem without believing that we will have a vaccine. If we get one and it works, that's wonderful, I will celebrate. But if we say, you know, just keep California shut until we get a vaccine, that's going to be the end of California or of any California.
Okay, thank you. Another question, perhaps more relevant to Greece, has to do with tourism. As you know, Greece opens its borders to tourists from countries that with relatively few COVID-19 cases right now, but also to countries with many cases and deaths. And the country's economy strongly depends, of course, on the tourism receipts. However, we are taking, as a country, a huge high risk with a high percentage of old people that are in Greece and many islands that have very poor medical infrastructures and limited number of doctors. Which, in your opinion, would be the ideal action scheme for a safe environment, both for tourists and for residents?
So Greece probably has a very, very low level of activity at this point. I cannot tell that it has zero, but it's likely to be very, very low. I think it's very likely also that Greece had a very low infectious load to begin with, because when the epidemic wave hit, you know, probably around January or February for Greece, this is a time when Greece is relatively backwater destination. You know, very few people travel to Greece in January. Also, the mobility of the population is relatively limited. And it's not just Greece. I think that most countries in the Balkans and Eastern Europe also have a very similar situation. Plus, you know, maybe our weather has also been very kind to us in one way or another. You know, Greece is so beautiful all year long. So I think that at this point, activity is very low. I think that from most locations in Europe, activity is also very low. Actually, it may be even lower than Greece because some locations did more testing. So we have a better understanding and also a better ability to extinguish the epidemic wave compared to Greece that did less testing. There will be tourists who come and who are infected. There's no doubt about that. And as I said, as a general advice, I believe that intensive testing makes sense. You know, when you're in the beginning of an epidemic, and also when you're at a stage where you have pretty much extinguished the epidemic, but you don't want to have recrudescence, you should do very intensive testing and then contact tracing for those people who are infected. I think we can do better in that. That will give us more security that we're doing things right. I have also argued for the need for having epidemiological surveillance with representative samples done every 2 or 3 weeks, because if you just wait for people to come who are dying, this is like 2 or 3 weeks after they're infected. And coronavirus waves are very rapidly emerging. We don't have a vaccine, which means that the epidemic wave rises very, very quickly, and then it goes down very quickly, as opposed to influenza that is more spread over an entire season. You know, influenza starts in September and goes slowly all the way through winter, fall, winter, and early spring. It's not the same with coronavirus. When it hits very fast. So intensive testing and tracing and epidemiological surveillance, I think is very essential. At the same time, of course, protecting all these vulnerable populations and settings, which, as I said, it's just 5 to 10% of the population. It's not necessarily more than that, even in Greece that has an elderly population.
Building on that, on the virality of the virus, have there been any studies that compare COVID-19 to other viruses in terms of how viral it is and how quickly it spreads, or what percentage of people get infected or will get infected?
There's many such efforts, and I have to say that eventually they tend to confuse people. And I fell into that trap myself. I was struggling to find ways to convey how deadly the virus is and how widely spread it is. So I went down the path of making a comparison to influenza. And people get very confused because they hear influenza and they say, oh, so this is the common cold. Yes and no. Coronavirus is causing common colds. You know, the garden variety coronaviruses, they're causing common colds. And the same applies to this new one in the large majority of people who get infected. But there's also some people who are devastated. There are settings that are devastated. You know, so the infection fatality rate ranges from 0.000 to 25% in a nursing home environment. So it's very confusing, and it has to be clarified. What are we talking about? Are we talking about the total number of deaths? If that's the case, then influenza is killing 300,000 to 700,000 people per year. On bad years, it can go to 1 million. In horrible years, it can go to 4 million. In 1918, it was 50 million. Now, coronavirus is 470,000 or so. And of course, we'll have a new season. And you have to take into account how many seasons are we talking about. Actually, the Southern Hemisphere is already a new season that we're counting at the moment. So we're like season number 2. Other coronaviruses like Ebola or MERS have nothing to do with this new one. They're extremely lethal, and just they don't spread that easily. If they were spreading, that would be the end of the human species. We're very lucky for that. I think it was very unfortunate that this new coronavirus was named SARS-CoV-2, because people immediately bring to mind SARS, which has a fatality that is enormous. And based on what we know now, the behavior of this virus is closer to the garden variety coronaviruses that infect almost everyone and can reinfect people and devastate specific environments like nursing homes and hospitals, pretty much like this new one. The problem is that this is the first pass of this new coronavirus in human populations. And anytime you have a new virus in the human population, you really need to be very, very careful because it can be devastating. The last garden variety coronavirus was introduced in the end of the 19th century. It was OC 43. And many people believe that the influenza pandemic of 1890 that killed 1 million people was not influenza, but it was actually OC 43, and it was its first passage in human populations.
Okay. Another question. I don't know if you have followed the case for Sweden, which is a country that has a different model compared to most of the countries around the world, which went into more strict lockdowns either sooner or later. Sweden has had a more lax, let's say, strategy. How would you rate this strategy, and do you think it has been successful, and have you followed the results in terms of both fatalities but also infection rate?
So we have to be very careful in comparing fatalities across different countries, because the seeding of the virus is extremely different. The mixing of the population is extremely different. The mobility of the population is extremely different. The age stratification of the population is very different. So comparing Sweden with other countries, you need to take into account all of these factors, and it's just almost impossible to account for all of that. Based on what we have seen, I think the Swedish model was really excellent in many aspects in terms of the level of social distancing that it tried to impose, where it tried to have citizens adopt measures, kind of self-responsibility, and keeping the society and the economy mostly open with, you know, more limited measures at the level of the state-imposed measures. It was horrible at the level of protecting high-risk populations. Sweden started very nicely doing a lot of testing. And after a few weeks, they said, no, we stop. We'll only test those who have severe symptoms and need to come to the hospital, to be in the hospital. Horrible mistake. You know, then you leave all the asymptomatic or mildly symptomatic people to circulate. Second mistake, almost nothing was done for nursing homes and for hospitals. We know that a large proportion of hospital staff in Stockholm were infected, and probably they were disseminating the infection to patients in the hospital. And of course, nursing homes in Sweden were also devastated. So it's not just one decision, but multiple decisions. The Swedes did it extremely well at the level of state-imposed measures. They were horrible at the level of protecting vulnerable populations and settings. Unfortunately, that second mistake was made by almost every country that had nursing homes. Greece did not have that problem. We take care of our elderly. We don't send them to nursing homes. You know, we're very nice with them, and I'm very glad for that.
It's true. I mean, on the other hand, you have a big mix of young people living with older people. So if the younger people are not careful, and because they're not in risk themselves, but because they come in contact very often with older people, sometimes it's hard compared to other countries where in their nursery homes, it's easier to protect the elderly population. But building on that, sure, go ahead.
True, but we have to be careful here because nursing homes are like ideal locations for becoming massacre places. You have all these susceptible people just next to each other and you know, at very close quarters typically. As opposed to the situation with the Greek family where indeed you may have a vulnerable elderly person, but it's very different. It's just one person. And not only that, we have to make a distinction between someone who's elderly but actually in good health versus someone who's elderly and is the type of nursing home person who is debilitated and, you know, bedridden and has 4 other diseases. The risk difference can be 100-fold or more between these two people who have exactly the same age. You know, someone who's 70 years old but is healthy has very, very low risk, extremely low risk. Someone who's 70 years old and a nursing home, if they get infected, they have 1 out of 4 chances of dying.
Okay. Another question from from the audience regarding the, let's say, the curve of the virus. As you said, it goes up very quickly. The number of infections and deaths, they go up exponentially, let's say, but then it also falls down pretty quickly in terms of what we've noticed from different countries. The question is, have you been able to analyze how the lockdown measures have been the reason for this drop in the number of cases and deaths, compared to just the virus doing its cycle, let's say?
So there's an interesting paper by the Imperial team that came out in Nature that basically concludes that it was the lockdown measures that eventually saved so many lives in several European countries. That paper is a bit problematic though. I mean, obviously these are observational data. So if you have observational data and you try to model, you're into like no man's land in terms of credibility. I mean, it's very exploratory at best. It's interesting that that paper says that Sweden lockdown had the same effectiveness, more or less, as lockdown in other countries. But Sweden actually didn't do lockdown. So, you know, they banned public events and they say that that did the trick, but actually that didn't do the trick in other locations. So the paper is already a bit self-contradictory in terms of what is lockdown. Now, what is lockdown? As I mentioned, lockdown is like 500 things. And when you say that I impose lockdown, maybe what you do is that you make people take a few simple interventions more seriously. So take Greece, for example. Before lockdown, we had thousands of people celebrating on carnivals, even though, you know, the state said, you know, don't have these events. So with lockdown, maybe what you achieve is a level of hygiene, like wash your hands, respiratory etiquette, wear masks when needed, and avoid mass gatherings, that you should have been able to do without lockdown. so it's not the lockdown, but the fact that just people start saying, oh, we do have a real virus. It's not a conspiracy. we need to wash our hands. We need to avoid really coughing in the face of our elderly parents. We need to, there's something real here. It's very difficult to say which among that bundle of hundreds of measures really did the big difference. But my suspicion is that more simple measures really were the ones that sufficed to make the difference. And complete draconian lockdown, I don't know how much it added, but it did. Even if it did, it has so many adverse consequences on health, society, economy, and beyond that we just cannot do it for a long time. You know, we tried it and you see what happened. You see devastated mental health, suicides, domestic violence, people not going to the hospital because of heart attacks. There's a suggestion that a large share of the excess mortality is not COVID-19, but actually people with heart attacks or other diseases who didn't get proper care. People at nursing homes who were not sent to the hospitals with heart attacks, they would have been saved. Conversely, people with COVID-19 were sent to nursing homes to infect the rest. So I think lockdown, okay, we did it. Congratulations to everyone. Never do it again. Never.
True. Regarding the one of the most talked about, let's say, measures for post-lockdown opening of the economies are the tracing apps. Have you followed that at all? And do you think that it's actually something that can help? Is it something that's actually realistic for it to be used and have a meaningful impact on stopping the spread of the virus?
I'm a little bit concerned about this technology. I think that like any intervention, we have to look at both the benefits and the harms and the repercussions. And I do worry about the repercussions of that technology. I would like to see some good trial. I mean, there's no reason why not to do a trial to see how effective they are. I mean, you know, here's a wonderful example of trying to overkill in terms of tracking one's life and contacts and where they are and what they do and who they got in touch with. And before implementing it, I would like to have some better evidence. We have so many other tools that we can do pretty well with that. Do we really need that extra one? Maybe we do, but I'd like to be very, very cautious about it.
Okay. A bit of a politics question next. I think in some of your initial, let's say, papers and lectures on YouTube or other media channels, they were embraced by the right, let's say, especially in the US. Where's your presentation today? And I think the way that things have unfolded, it seems now that what you're saying today is more embraced by even the more liberal people, or the more liberal spectrum of the political spectrum. How would you respond to that, and what's been your experience, let's say, throughout this past 3-4 months, where politics are a crucial part of everyday life, especially when the stakes are so high?
Great question. My experience has been horrible. And I think it's a pity when science mixes with politics. Science should not mix with politics. I believe that as a scientist, it's very difficult to get to the truth. We're doing our best. We work day and night to do this. And then we say, we have a glimpse of some evidence. I think I have something that is close to the truth, and let me tell you what I found. It is horrible if before you say what you found, you have to do a poll. What is the opinion of the day for the right, for the left, for the center right, for the extreme right, for the extreme left, And would my truth, which is a number, it's a number, the infection fatality rate that we found is 0.18 or whatever. Would that serve the right? Would that serve the left? Would it serve the center? You cannot do science this way. As a scientist, I think that you need to just say the truth, try to avoid having conflicts, try to avoid having any political ideology. I mean, many scientists have political ideology. They're just citizens like all citizens, but they should detach from that. They should not have that interfere with their science. And I think that that belongs also as an advice to critics of scientists. I think that some of the criticism that was launched against scientists, including myself, it tried to present them as serving some sort of ideology. In my case, as you say, at some point they said that that could be conservative ideology, which, based on my track record, seems to be a very weird type of explanation. So it's a pity. I think it's a pity when politics and science intermerge, when politics subverge science and do not allow it to breathe. Science needs to breathe. It needs to be free to express what it has found, regardless of whether people are liking it or not.
Okay. Another question that's more Greece-based. Have you been in contact at all with the Greek COVID response scientific team throughout this period? What sort of, if yes, what sort of conversations or dialogues have you had with them?
I know Sotiris Chodras. For many years we were at the same year in medical school, and he's a friend for ages. So we exchanged a few emails, but never had any official invitation or any official kind of contact with the Greek team. I mean, I think that they have great scientists on board, and I think that they did their best. My recommendation, both to Greek colleagues and to other colleagues who asked my opinion from many countries around the world, was to try to look at the totality of the evidence. I think that most countries got in their response teams a number of excellent infectious disease people, but actually this is a situation that you need expertise from across the board. The disease, first of all, is not so much of an infection, it's more of an immunologic reaction. So I would say immunologists would be probably at least as relevant. But then you need to have sociologists, you need to have economists, you need to have public health people who are looking at big picture impact. And of course, epidemiologists, but many, many other specialists. We're facing so many challenges at the moment. This is not an infectious disease. This is a crisis of multiple dimensions. You cannot model just the number of COVID-19 infections. As I said, the number of tuberculosis infections that may be getting out of hand, maybe like 10 times more. And the impact on economy and indirectly then on health could be far more severe. Some people said that here is a situation where we're deciding, do we care about health or money, the economy? I've never heard anything more ridiculous. If you destroy the economy, you destroy health. First you will kill the elderly and the susceptible, and then you will kill also the young. We know that. So saying that it's health or economy is like a complete misrepresentation. Personally, I don't care about money and the economy. I mean, I'm a physician. I want to save lives. But to save lives, you cannot have a destroyed healthcare system. To save lives, you need to have hospitals that are functioning. To save lives, you need to be offering the right services to people. Otherwise, you're just killing them sooner or later.
Okay, we'll do a few more questions, if that's okay with you. And I know you
Absolutely.
have a busy schedule. Another question on medication, or let's say how to deal with the symptoms. Is intravenous vitamin C or high levels of vitamin D, high levels of zinc, are those valid means for fighting the virus. There have been some studies in China and also in some US hospitals where they have been reported substantial results. And also Dr. Chrusos, MD, has also reported on vitamin D. What do you think about this sort of therapies for the virus?
George Chrusos is an amazing scientist and a great friend also. I'm not sure whether he is proposing these treatments or not, since you mentioned his name.
It's a question. I mean, from one of the audience. I have not heard it myself, so I cannot.
I personally haven't seen data that are sufficiently strong to make me believe that these interventions are going to be effective. Maybe I missed them somehow, but what I have seen is not convincing enough in any way. And I have to say that unfortunately with vitamins, we have a long track record of literature that is very unreliable, claiming major effects for almost any disease you can imagine. And vitamins are great things. I mean, we need vitamins; they're indispensable. But I don't think that I would have them as first-line treatment for COVID-19 or prevention or treatment. Now, if better evidence accrues, I'm willing to revisit that.
Okay, thank you. A Stanford question. So Stanford right now is, of course, during summer, things are pretty quiet, and in the previous semester, a lot of the students had to leave the campus. Very few people stayed there. What do you think about the fall semester? Do you think that the students will return on campus? Should they return on campus? How is the university responding? And what are their plans, if you know about that, for the fall?
So plans are evolving on a daily basis. I think that the leadership is thinking very, very hard about that, and I don't want to be in their shoes because it's a very difficult set of decisions, and I'm sure that they're doing their best and trying to accommodate both the students and also health and risks at the right balance. Personally, I'm in favor of being a bit more bold towards returning to normality. At the same time, though, keeping very close eyes on the epidemic. So, with strong science, with strong data-driven collection and affecting decision-making downstream. As I said, no one has a clue whether there will be a second wave, and if it comes, when it will come, how big it will be. But even if it comes, if we are prepared to deal with it, it will be much, much better compared to what happened the first time round. I have no doubt about that. So I would urge academic leaders to dare to be a bit more bold with returning to normality. I mean, we have lots of options, and of course we can have an online university. That's what we had for the whole quarter, more or less. But to me, this is not really a university. It's it's a very different thing, and I would hate to see our universities die in an online transformation.
Okay, I think we can end here with the Stanford question, since it's close to the heart to a lot of the big part of our audience. I would like to thank you very, very much for your time and for your very, very useful insights. I'm sorry, I have to say sorry to the audience for not being able to cover all questions, but time is limited, and I think this conversation that we're having is a ever evolving conversation as new information comes to light, as a second wave will or will not hit us in the fall. So hopefully things will turn out for the best. Perhaps in the future we will have the opportunity, Professor Ioannidis, to have you again on our webcast and go over the newest information that you have managed to gather and analyze. It's been a great honor to meet you and to have this conversation with you. And I wish you all the best.
A million thanks for this wonderful invitation. It was a great honor for me. And I wish the best to all the panelists who joined today. Thank you.
Thank you very much. If for the audience, if you would like to learn more about our future webcasts and events, you can see now on the screen our email and also our LinkedIn page. So if you can follow us or you can email and we can add you to our mailing list. Thank you very much again for your time this morning or evening or afternoon, depending on where you are around the world. And enjoy the rest of your day. Okay, goodbye.